Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Outcomes of Double-Hit Lymphoma Patients Who Achieve First Complete Remission by Landsberg et al. My name is Kieran Dunleavy, and I am Professor of Medicine and Director of the Lymphoma Program at George Washington University in Washington, D.C., USA. My oncologic specialty is the treatment of lymphoma and lymphoproliferative disorders. Although most patients with diffuse large B-cell lymphoma have excellent outcomes following frontline therapy, there remain a significant proportion of people for whom standard R-CHOP therapy is inadequate. It is critical to attempt to identify patients who will have an inferior outcome following standard therapy, as they may benefit from alternative strategies. While we have done a very good job of identifying good clinical predictors of outcome, such as those characteristics in the International Prognostic Index score, the role of molecular biological factors in predicting survival is much less well understood. Early studies in diffuse large B-cell lymphoma demonstrated that the disease could be broken down into molecular subtypes according to the stage of B-cell differentiation that it originated from, germinal center B-cell or activated B-cell for the most part. This finding has clinical relevance in that patients with these subtypes have disparate outcomes following standard therapy. But beyond cell of origin, there are many additional important biologic predictors. There's been a lot of recent interest in MYC-rearranged diffuse large B-cell lymphoma, including double-hit lymphomas, as they are particularly aggressive diseases with very poor outcomes and so far little consensus on how they should be optimally treated. Double-hit defines cases with a chromosomal breakpoint affecting the MYC8q24 locus, and in addition another recurrent breakpoint, usually BCL2 or BCL6. Our understanding of these diseases is somewhat complicated by the fact that recently several groups using immunohistochemistry have identified that a significant number of diffuse large B-cell lymphoma cases have high protein expression of MYC and BCL2, and most of these cases are without translocation. These so-called double protein expressor cases also fare poorly following standard R-CHOP therapy. Unlike double-hit cases, mostly of germinal center B-cell origin, double protein expressor cases that do not harbor translocations are typically of activated B-cell origin, and this is an important therapeutic consideration. Classifying these diseases has been challenging, and in that respect, the most recent revision in 2016 to the WHO classification of lymphoid tumors is very welcomed. Previously, a high proportion of double-hit lymphoma and MYC-rearranged lymphoma cases were placed in a category called BCLU, which stands for B-cell lymphoma unclassifiable, with features in between Burkitt lymphoma and diffuse large B-cell lymphoma. But the criteria for inclusion in this category were vague. The current category where these lymphomas are placed, high-grade B-cell lymphomas with and without MYC and BCL2 or BCL6 translocations, has much clearer inclusion criteria for these diseases. As double-hit lymphomas are rare and there are thus far no prospective studies to inform on their treatment, there's a lot of controversy as to how they should be approached, and many have advocated for intensive upfront therapy as well as consolidation autologous transplantation. To these questions, the study published in JCO by Landsberg and colleagues is very helpful. In a retrospective multi-center series, they looked at the outcome of 189 patients with double-hit lymphoma who achieved complete remission. As has been demonstrated in other retrospective series, but with much fewer patients, they show that patients did better following an intensive upfront regimen, dose-adjusted EPOCH-OR, or Codex-M-IVAC, or OR-Hyper-CVAD, compared to OR-CHOP. Their second question was on the role of consolidation transplant in patients who were in CR at 3 months after completing therapy. And as others have shown in smaller numbers, They showed that performing a transplant in this population did not give patients a survival benefit. My interpretation of and conclusions from the study are that first, there is no known role for performing a consolidation transplant in patients with this disease. This question, of course, should ideally be answered in a prospective randomized setting, but that will be difficult given the rarity of double-hit lymphoma. But in the absence of that data, this and at least 2 other recent studies show no benefit of the approach, so it should not be routinely done. Second, there are now several studies that demonstrate a survival advantage for patients who receive upfront approaches that are more intensive than R-CHOP. As double-hit lymphomas are characterized by high tumor proliferation, it makes sense that approaches that are effective in Burkitt lymphoma may have better efficacy in these diseases. One of the challenges with intensive approaches is their tolerability, as most patients with double-hit lymphoma are over 60 years, and in that respect, intermediate intensity approaches like dose-adjusted EPOCH-R may be optimal in these diseases. A multi-center study of the regimen in 53 patients with MYC-rearranged diffuse large B-cell lymphoma, approximately half of who had double-hit lymphoma, recently concluded, and final results should be available soon. In conclusion, double-hit lymphoma represents a big therapeutic challenge and unmet need. This current study is helpful in identifying the importance of intensive approaches as well as the non-benefit of consolidation transplant in the largest number of patients looked at to date. These diseases have many interesting targets for small molecule inhibitor investigation, and novel approaches such as CAR anti-CD19 therapy may be helpful in the future. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.